All right, so here is our SOAP note presentation for us. So remember, after every single patient encounter we have, we're going to be documenting against it. Now, a lot of times it's going to be electronic documentation, but the format, no matter what we use, electronic or handwritten notes, the formatting of SOAP notes is going to be the foundation. So we're going to get really, really good at that this semester. So why do we document? Well, one, it's a legal record of what you do during your treatment. So that's incredibly important. Payment. Most of us want to get paid for what we do. So unfortunately, we have insurances that are going to help reimburse us. So we're going to have to document that we actually did something. Other reasons, especially with electronic documentation, is we can do a lot of research. We can collect a lot of data with it. And that's really fun to see in the last couple of years, some big data, some research with big data coming out. But I would say the most important reason is the communication to our coworkers, whether it be other therapists, uh, and medical doctors, nurses, case managers, workers' comp adjusters, insurances, on and on and on. It's incredibly important to share our communication, our thoughts, to be part of that healthcare team. So when we do document, again, no matter what format we use, it's going to be, we want to be accurate and specific, but brief, as concise as possible without omitting any information. If it's handwritten, we want it to be legible. In any other language, whether it's handwritten or typed, we want to have clear language. Professional, as always, always date and sign your notes. Some are going to require to timestamp your notes as well. And again, electronic documentation basically takes care of that for us. If it's handwritten, we don't want any extra spaces between lines, because what could happen is somebody could go back in and write in between the gaps that you have, and that would alter the note. That's not what we want. If it is handwritten, again, we use a black pen. The reason for that is because blue pens don't show up on copies and fax machines. So that's kind of an older rule, but we should be abiding by it even right now. If we do make an error, what we want to do is we want to have a single solid line with your initials and date at the end of that line. We don't ever want to scribble it out, black it out, or white it out, because what we need to do is we need to be able to read what was written. And that way, there's no question of what did that word say, should an attorney get a hold of those notes down the line. So single solid line with date and initials. And you know what? When I was writing on in handwritten notes early in my career, there was more than one occasion I would write an entire note on the wrong chart. I'd have Timothy Johnson and John Timison, and I would swap their notes, and I'd have to single solid line through the entire note, date and initials, and then right there, correct that, right there, correct note. So all physical therapy documentation starts with a PT evaluation. Obviously, the physical therapist does that. They do the examination, then the evaluation, and then they generate the diagnosis and plan of care. The plan of care is going to include short-term and long-term goals. The goals should have this basic format: audience, behavior, condition, and degree. So the audience is almost always the patient, but sometimes it's going to be the family or caretaker or someone else. The behavior that we want to see. So most of the time, increase range of motion, decrease dependence, improve ambulation, decrease fall risk, whatever that behavior might be. Increase strength. Condition, so the circumstances when it occurs. So sometimes we're going to want to get our patient from ambulation with mod assist to min assist, or mod assist to contact guard. What is the device? What level services? Even ground, uneven ground, whatever it might be. When do we want to see that? Obviously, we can think of our outpatient and athletic type of patients, and the conditions that a basketball player needs to come back from an ankle sprain is entirely different than a hockey player. So yeah, we want to be really specific on all of those conditions. And then the degree. So what's the minimal number we'd like to see, number of reps, time, percent, whatever it is. So what is the standard for success? So within 1 week, 100% of the time with min-Qs would be an example of the degree. So just to go back, you guys won't be writing goals, but you'll be reading them an awful lot. Because again, that's that plan of care. That's the recipe that you guys are going to be following. So we have long-term and short-term goals. Long-term are the function-based goals. So that's the, that's what the patient's complaining about. They're complaining of pain, but they're complaining of pain that's stopping them from doing something. It might be sleep. It might be playing with their kids. It might be sports. It could, who knows? But it's really what is the function that is impaired? So the long-term goals are going to be function-based, ambulation, transfers, balance, some sort of salient function to that patient. The short-term goals are impairment-based. So that's what we can measure. So typically therapists work on the acute or subacute, so the early stages of rehab that's contributing to the decreased function. So that's the range of motion. DF is dorsiflexion. We're going to use that example down the road. In this presentation, the weight bearing status, the strength, what is the thing that we need to improve upon? If we can improve upon the strength of the lower extremities, then walking upstairs will improve, right? So work on the short-term goals of increasing manual muscle test strength of the lower extremities to 4 out of 5 grossly. If we can do that, walking upstairs will be better. And then we can start superimposing the functional based tasks on top of that. So again, short-term and long-term goals. Now, don't get too confused on the short-term versus long-term terms. As we've talked about in the hospital setting, the long-term goal might be 3 days and the short-term goal might be this afternoon, where in the school setting, the short-term goal could be next year and the long-term goal could be in 4 years. So it's don't get too hung up on the word short-term or long-term. The setting will help determine the length of time for these goals. So let's get into it. So during this presentation, I put this together with the help of a handful of textbooks that aren't assigned to you. If you want access to them, I can show you what I used. But I will be clear when I'm talking with my own personal judgments, but most of this stuff is straight out of the textbooks that I used. So I will make a note where I have strong feelings about something. So subjective, I always think of this as what the patient says with their mouth. Really important on a written exam type question, right? So if you're reading a written exam and anything that says patient states or patient complains of or patient notes, like that's all the whatever follows those words that's information coming from the patient's mouth. So you should be able to get the correct answer on any sort of quiz or exam by thinking of that. Now there is some exceptions to that. In some cases, family members are going to be telling us information for the patient. So definitely in pediatrics, sometimes with cognitive impairments, sometimes there's speech impairments on top of whatever else we're seeing. So it's not always just the patient. Sometimes it's a family member. But for right now, let's just stick with the patient. I think that's good 90% of what it's going to come from. So we want to be as specific and relate it back to function if we're able. We always want to be relating everything we're talking about back to function, because ultimately that's the thing we're going to be working on. If I get my patients up and down stairs safely and efficiently, but their lower extremity strength never really progresses beyond a 3+, the patient's going to be happy. If I get my patient's leg strength to a 4+ out of 5, but they still can't walk up and down stairs for some reason, then we didn't do our job. So always relate everything back to function. That's always something we're going to want to be able to do. So when we talk about pain, this is a really good example. So patient states that pain is improving. Well, that's just not enough. That's good news, but that's just not enough. So patient states that left hip pain is 4 out of 10 when walking, 6 out of 10 last week. Now that is a much better, much more thorough information set without being rambling and too long. So not only do we have the exact location, the intensity, and then we also have the function. And it was nice that the patient noted last week it was a 6 out of 10. This week it's a 4 out of 10. That was really nice of them to do for us. Most of the time, we're going to have to talk about that later on in the note. We'll talk about that in a little while. But that's way better information. If we just stuck with that first sentence, the patient states that pain is improving. Okay, well, why do we need more physical therapy then? How come we can't discharge right now, right? So we always want as much information as possible. One, to show progress. Two, that we still have functional deficits that we still need to work on. Now, sometimes our patient tells us a lot of information, and we want, again, these SOAP notes, we want to be as brief, as concise as possible without missing any data. What can be annoying to read is a bunch of patient states sentence. So if you were to see patient states my hip is feeling better at night, patient states position of comfort is left side lying, patient states it feels better when it's sunny, patient states I only, whatever it might be, that rambling on and on and on, patient states over and over again, that gets to be very long-winded. We can replace patient states with a semicolon. So we write patient states at first, and then any other time we need a patient states, we put that semicolon. So patient states my hip pain is improved at night, semicolon, position of comfort left side lying, semicolon, I'm only happy when it rains, semicolon, whatever else it might be. So we should be complete with our thoughts, not necessary to have complete sentences. Now, I've had some people, when I give this presentation, other therapists challenge me on this. And this is coming from the textbook, be complete with your thoughts, not necessarily with complete sentences. I think what the key is to be informative and readable. If it's not readable, if we're confused as we're reading your notes, then that's not helping me as the next therapist. So just make sure you have clear communication, but it is not necessary to have perfect sentence and paragraph structure. So we've got a little SOAP note we're going to start writing. So sometimes the facility that you work in will have you put the goal that you're working on at the top, and then you write your SOAP note. That's not always. I don't see that very frequently, but it is really nice to help anchor exactly what are we working on. So this patient that we're going to be working on had an ankle sprain. They're going to try to get back to sports. So the goal is patient will increase dorsiflexion range of motion by 4 degrees in 5 days. All right, good. So we treat our patient, we talk to our patient, patient states, ankle feels like it's moving a little more. Okay, not bad. I think we can make that a little bit better. We'll look at some ways we can make our subjectives better in a minute. So here's a little drill for you. What I want you to do is read this list of 7 statements, and you select the ones that should belong in the subjective part of the SOAP note. Go ahead and pause your screen as you read it. When you come back, we'll see if you're right. Go ahead and pause now. All right. So I hope that you picked these. So we'll get into all of these down the road and why these aren't. We'll see where these other ones fit. But patient complains of, right? So there you go. There's that cue, right? Where's this information coming from? Patient complains of pain in left wrist. That's coming from the patient's mouth. States his goal to return to sports ASAP, right? States his goal, right? That's coming from the patient's mouth, complains of pain. And there you go. There's another example of that concise sentence, but not necessarily the formal, correct. Your 10th grade English teacher would probably not like this sentence structure. Complains of pain in the left low back when sitting greater than 10 minutes. So, we can call back our English teachers and say, see, I was right all along. So The next drill I want you to do, though, is these aren't wonderful subjective statements. Based on your knowledge, let's see if you can edit these subjective statements and make them a little bit better, or at least identify what's missing. So you can go ahead and pause again, figure out, jot down how you think you could make this better, and then we'll come back and talk about that. Go ahead and pause and work on it. All right. So let's see. Excuse me. So this first one, patient complains of pain in left wrist. Okay, so we have left wrist. Man, if we could be even more specific, anterior wrist, palmar aspect of wrist, dorsal aspect of wrist, maybe even noting, towards the ulnar side or radial side, like even better location would help us, but this is okay. What we are missing, hopefully you got, is the pain rating of some kind. Numerical rating scale, NRS, the easiest one to do, 0 to 10 scale. We could have done a Wong-Baker or the visual analog scale, but what is the rating of pain? And then with what function, right? So I care if you have pain every single time you try to drive. I care if you have pain in your wrist every time you try to put a belt on. I care if you have pain when you're pushing up from a chair. All of those things are really important. It's good to note if you have pain when you're hang gliding, but that's something that's a really specific task. So exactly with what function is important. Patient states his goal is to return to sport ASAP. Okay, good. What the information I'm missing here is what sport, sometimes what position. Hockey goalie is a heck of a lot different than the right wing. So what is the sport? And then why is it so important? Are playoffs in 2 weeks or are they not? Remember, we're documenting against things that might go wrong as well. So if we have a young athlete that's willing to cut some corners and maybe be too aggressive, and they might end up getting hurt worse because they're just being their own, thick-headed charge against it themselves. We want to be able to say, hey, we said all along he was really doing the wrong things. Patient complains of pain in the left low back with sitting greater than 10 minutes. All right, well, hey, that's pretty good. We're missing the intensity rating, but man, not only do we have exact location, left lower back with the function, and man, we also have a time with it. Wow, that's really nice. Now, if we could just get that intensity rating, then we've got a bunch of data that we can document against, right? Because if today he has a 5 out of 10 low back pain, left low back pain with sitting greater than 10 minutes, if in 2 weeks he has 5 out of 10 back pain with sitting, but now it's up to 25 minutes, all right, well, that's functional progress. We're heading into the right direction. So really important to document fully. All right, let's figure out this last one. Patient states that her children drive her crazy. Patient states that her shoulder pain is improving. Patient states that she forgets what she has trouble with. Patient states that she loves the wand thingy. Wow, that is a lot of information. So the first thing we can do is we can eliminate all of these multiple patient states. So patient states that their children drive her crazy, semicolon, that her shoulder pain is improving, semicolon, forgets what she has trouble with, semicolon, she loves that wand thingy. That wand thingy, by the way, is ultrasound. We'll talk about the pros and cons of ultrasound next semester. So the other thing you might think here is there's a lot of information here we might not need. And that's true. Without actually seeing the patient, man, we could probably cut this subjective section down significantly. However, you also have to think of yourself in your patient's shoes. If you've got 3-4 kids that are going crazy, like she says, and sometimes busy moms put themselves last and take care of their family and their household first. So when she forgets what she has trouble with, that doesn't necessarily mean she's ready for discharge. Sometimes she's just not taking care of herself. So I think we need more data here, and the rest of the SOAP note would help us down the road. If we were to read the rest of the SOAP note, we as therapists can say, patient very stressed out, not taking care of themselves, not adhering to home exercise program, and kind of justify why the progress was slow. If her shoulder really is better, then we can probably eliminate a lot of this stuff and just say patient says shoulder pain is improving. Hopefully we get some sort of rating there. Hopefully we get some sort of functional task, and then we can start gearing up for discharge during the treatment. All right, moving on to the objective section. So objective is what the patient says with their body. So any data we get from their body, right? So again, that's my way to remember. So on a written exam, if you see, the question of here's this next 3 sentences, what part of the SOAP note should this belong to? If it's information about the patient's body, that's going to go in objective. So all of our vitals documentation, all of our updated measures, whatever it might be, make sure we use that full scale or full grading system. So it's a manual muscle test of 3 out of 5, not just 3. RPE of 8 out of 20, not just 8. Because again, with the modified versus original Borg, there's a big difference between 8 out of 20 versus 8 out of 10. So make sure you use that full scale when you document that. And with next semester, we'll talk about how do we document for physical agents. So we want to look at what is the type of physical agent we're using, hot, cold, ultrasound, e-stim, what is the exact type, what the exact location is, and then all the other parameters around it. How long did it last for? Is the duration? What number do we ramp it up to? We'll look at all of that next semester. Exercise parameters, we definitely want to include all of the information that we possibly need. So what is the type of exercise? What is our patient position? How many sets and reps do we do? What kind of load are we using? All of that's really, really important, right? So if you just said squat, body weight squat, 3 times 10. All right. The lack of exact depth concerns me with that. So are we squatting our rear end all the way down to our heels to roughly 90 degrees of knee flexion? So any of that information could be very helpful. Gait deviations, any level assistive or equipment we used. I think I gave the example way back, I think in the first day we met together. So did we ambulate 35 feet or do we ambulate 35 feet with contact guard assist, with rolling walker, with step 2 gait pattern? Man, if we document all of that other stuff, then we have a ton of information to measure small levels of progress with. And obviously I'm a table guy. You saw, I think during tests and measures, how tables make things really easy to read. So tables and make things really easy to read, especially when we've got 15 to 25 notes to read before we even start our day. We want things that are easy to be read. We can break information into categories if needed. So take all of our strength and range of motion measures, put it in one. Then we could talk about gait. Then we could talk about whatever other balance or transfers information that we need there. So just remember to keep this as organized and clear as possible. The more organized and clear, the easier it is to read down the road. And really, when it's a complicated treatment, this organization can really save you some time. Now, in most outpatient settings, you're going to use a flow sheet. Those are just extra sheets of paper. So those are the physical pieces of paper that exercises are written on and documented on. And in your objective section, when you talk about exercise, you can write see flow sheet. But anytime we make changes from the last visit, those changes should be documented in SOAP note. So if you've got 5 different exercises your patient's doing, but one of them you changed, in the objective section, we could say exercise C flow sheet, changes to squats, added 10 pounds each hand, right? So we want to document what changes we are. Because if that flow sheet ever gets lost, as long as we're documenting the changes, then we can recreate the flow sheet based on our notes. It would be a little bit of a pain, but we could do it. So that's important to remember. So this is what a flow sheet would look like, right? So here's our list of exercise down on the left-hand column. Here's the dates of service. Here's exactly how many reps we did or length of time or whatever it might be. And so this is very, very common. I will tell you, I hate seeing this because, man, it does not look like we are making a lot of modifications throughout this treatment. It looks like the person on April 6th did the exact same exercises that they did just over a month later on the May 11th. So, is our patient changing? Yes, of course they're changing. Why are they doing the same exercises? If we were to look really into the maybe these bike parameters down in the middle of the page, I see some minutes and level changes there, but man, it's really minimal. So once we learn about exercise, we are going to be making sure that we're better than this. So back to our running SOAP note that we're writing. Dorsiflexion passive range of motion 0 to 3 degrees was 0 to 1 degree at eval. All right, so that's good. So we're improving, making progress there. Any other information from the body would go there as well. So we're going to pause. You can read through our list again and think about all of the O's. So select all the O's. Go ahead and pause and work on that. All right, welcome back. Let's see what you got. So this number 2, strengthen lower extremity within normal limit. That you will see that WNL within normal limit, WFL within functional limit. I put that in the objective section, thinking that the therapist did manual muscle tests, screens, and just said, okay, everything's fine here. So instead of writing, left hip flexion 4+ out of 5, left knee extension 4+ out of 5, left knee flexion 4, instead of writing every single motion, they just kind of clumped it all together and said within normal limits. Down at the bottom, all of our vitals, right? Hopefully you got that one. So I want to go back to this. Obviously, we're missing a lot of information with these vitals, right? What are our units, right? Heart rate, beats per minute. Where's our rhythm? Where's our force? What limb do we use for blood pressure? And then units there, respiratory rate, same thing, units, rhythm, and depth is what we're missing there. So the next drill we have, look at this information. There's a lot here, but this is basically just one treatment a very common treatment. So what I want you to do is pause here and make this more organized. You can break it into categories. How would you organize this information? So go ahead and pause and work on that for a little bit. All right. So I hope that you got maybe the vitals in one section. You have other data, the strength testing we did, kind of that data we would do in one area. I think that maybe the exercises would be another good category. The modalities, another category. So that's how I would start thinking about these things. So I would go vitals, basic exercises, functional exercises like ambulation and transfers, and then our modality as well. So those are the categories I would think of, but anything that's easily read is good. Another tip for your categories is you could also do it basically in the sequence of the visit. So the first thing we do before we exercise with our patients are take their vitals. So that would go first. And then we would write all of the exercises we did. And you can easily write it in order. And then if you do modalities at the end, you could easily write that. If you did modalities in the beginning before the exercises, you could do it in that order. So sometimes it just helps to put things in the order that you executed them during your treatment and not just categories. But basically, our treatment is going to fall into chunks of categories anyway, so the two should be pretty similar. All right, assessment section. So the assessment section is what the therapist says with their brain. So we're looking at the subjective and objective data and relating it back to our goals, the problem list, to answer basically 3 questions. Are they getting better or worse? Do they still need therapy? Is there still a problem? One thing I need to throw in here also is any additional details about your treatment. So if you felt like you messed up on the blood pressure readings because it was too noisy, then you would need to write that. If the patient was late, that's why you didn't do 3 of the exercises, you would put that. So not only do they need therapy, but what's unique about today's treatment that you wanted to expand on. And then how is your treatment going to improve their function, what towards their long-term goal? For people who aren't us, the physical therapists and physical therapist assistants, it doesn't make sense how improving dorsiflexion range of motion will help somebody play basketball. So we need to write that, right? With increased dorsiflexion, patient will be able to go up and down stairs pain-free, be able to sprint, be able to jump, be able to return to sport. So how exactly, why are you working on dorsiflexion? It is tying back to their function. So you want to write this information concisely where someone who doesn't have your expertise can understand it. Really, really important in the inpatient settings, hospitals, skilled nursing facilities, and even a home care, because we have a bigger team that's working with this patient than just physical therapy. We've got nurses, we've got OTs. So when we work on transfers with the patient in the afternoon, the nighttime nurse is going to read that note to figure out when this patient needs to go to the bathroom at 3 o'clock in the morning. Do I need to bring help in? Are we going to the bedside commode, or are we walking to the bathroom? So they are going to be reading our notes to help them in their jobs, just like we're going to be reading their notes to help us in ours. So just remember, if you have any conclusions, you should have supportive data from the subjective and objective section to support it. We don't want to just say patient's getting better, but in the patient states that they haven't improved and their objective data, they haven't improved range of motion or strength. Well, why are we saying they're improving? If they're not, they're not. So you can also point out inconsistencies. Sometimes what our patient says doesn't match what their body is telling us, right? So Joan, she's in a level 10 out of 10, right? So Joan, how's your pain? 10. That the assessment section is where we get to describe difficulty with accurate pain reading, how the lack of nonverbal communication of pain was there. So, right, just pointing out those inconsistencies. What was hard? Why didn't you gather data? Why you didn't perform an aspect of the treatment, or to justify your change to the treatment. So patient improving strength. So we increase intensity of squat exercises. So why you didn't perform an aspect of treatment, right? So they came in and their swelling was way better. I didn't need to ice their ankle. So you would write that why, right? Why did you make that change? Really include any information that the next therapist would need to do their job. So any collaboration with PT or other professionals will go in here as well. So if you took a phone call from their surgeon and they said, hey, they're okay with progressing their weight bearing. So instead of just toe touch weight bearing, they can be partial weight bearing, or they can weight bear 50 pounds or whatever it might be. Alerted cardiologist about irregular heart rate rhythm. Cardiologist said it was okay to exercise below 110 beats per minute. Whatever that might be, that would go into the assessment. All right, so here's our SOAP note again. So in our assessment, patient's range of motion improving slightly. Okay, good. Increased dorsiflexion range of motion will normalize gait mechanics and enabled patient to improve function. All right, so that's good. So why are we working so hard on this dorsiflexion range of motion? Good. All right, another drill. Select all the A set statements, all the statements that would belong in the assessment section. Go ahead, pause, and give yourself a little time to do that. Let's see what we got. So decreased lower extremity strength limits ability to stairs, right? Where is this information coming from? The therapist's brain. Patient unable to communicate, thus unable to form pain scale. Great. Sorry, right? Difficulty with gathering information. Why was it difficult to gather that information? Well, they can't communicate. Good. Strength testing difficult due to patient's inability to follow commands. If you've ever worked with kids, or if you're going to down the road, there you go. But also traumatic brain injury patients, patients with traumatic brain injuries that have trouble with attention spans. Now, one thing you might see tolerated treatment well, um, you will read this in notes, and I think it is complete shortcut hack. I do not want to see any of our students write this. It doesn't give me any information to help for the next visit. If you just write tolerate treatment well, first of all, our patients should always tolerate our treatment well. If the patient doesn't tolerate our treatment well, we did something horrifically wrong, right? We put them on the bike, we jacked up the speed, and we had them at 9 miles an hour running up a 20% incline. And gosh darn it, they had a heart attack. I guess they didn't tolerate that very well. Our patients should always tolerate the treatment well. Sometimes it'll be challenging, but they should always tolerate our treatment well. We screwed up royally if they didn't. So it gives us no information. First of all, the patient should tolerate it. Second of all, it gives us no additional information to think about this patient. So it's a complete shortcut, and it's unacceptable in my book. So we want more information than that. All right, off to the plan section. So plan, another shortcut you will commonly see, continue PT. Well, no, we need more than that. What changes for the next visit are you going to make? The patient is not the same over and over again. And if they are, physical therapy is ineffective for them. If physical therapy is ineffective for them, we need to change something to make it better, or we're not the answer. So, what changes do you anticipate on making? Then what do you plan to remeasure if you need to? Some things we wouldn't measure every single time. I'm not going to measure posture. I'm not going to do a posture analysis every single visit because I don't expect it to change. I'm not going to do a 2-minute step test or a 6-minute walk test every visit because I don't think it's going to change today versus next week. So what do you think you're going to remeasure? What's the realistic things that you think you're going to measure? What will the patient do prior to the next visit, right? So this is immediate for the next visit. Think of plan as the next visit. What changes are we going to make to the treatment, and what's going to happen in between the next visit? Is the patient going to do something, or are they going to go do some home exercise program? Well, we're going to give them home exercise program. They're probably not going to do it, but we'll give it to them. Are they going to see their MD? Are they going to see the primary care, orthopedic surgeon, neurologist? Do they have a big appointment coming up? Or what is the therapist going to do prior to the next visit? Your safety net as PTAs is you always get to write consult with PT, but instead of just consult with PT, you want to be specific on what you're going to talk about. So consult with PT about adding standing dorsiflexion range of motions, stretching, whatever it might be. That's probably the thing that you could do. If it's within the plan of care, we would expect you to do that. If there's something outside of the plan of care, if I forgot to write balance testing or balance treatment, and you think, wow, this patient's balance is really bad, in the plan, you would say consult with PT about balance deficits, and then we could start working on it for the next time. Or are you going to research ultrasound and acute ankle sprains? So whatever, sometimes you'll have a question arise and you have to look into that. So with our running SOAP note, reassess dorsiflexion range of motion. Yeah, because that could change pretty quickly, especially for a younger athlete. Progress stretching to weight bearing if patient can tolerate. Good. Now let's have our last little drill. Go ahead and pause and select the plans. Let's see what you got. Increase weight for shoulder flexion exercises. Not bad. I want to see. All right. So if we wanted to improve upon this, I would say that we want to be exact with this, right? So if you're going to increase it by 2 pounds, right, increase weight by 2 pounds for shoulder flexion, or from red band to blue band, whatever it might be. Reassess swelling with girth measurements. We'll learn that actually pretty soon. Patient will be given HEP on shoulder exercises and walking program. So I'd like to be more specific on this, exactly what shoulder exercise, exactly what's the walking program. That's not bad for now, but that when we do actually give this home exercise program, HEP, then we're going to want to be specific with the exercises. So some additional thoughts: always write in a professional manner with appropriate terminology. Most notes are written from a third person perspective. So the patient's always referred to as patient and you are referred to as therapist or PTA. So this therapist examined this patient. Now, I've seen some of that move away in the last couple of years. So I often see patient referred to as their name, and usually therapist as this therapist, sometimes I. So I've seen some move away, again, moving towards the more personalized healthcare instead of more distant. So something to think about. That's, again, my thoughts. The textbook says notes are written from third person perspective. Be sure that you're within your scope of practice when writing the changes for treatments. Always make sure that it's within that plan of care. You cannot add things outside of plan of care, but what you get to do, your safety net, is also consult with PT about whatever your concerns might be. All right. So if we wanted to, let's look at this. So 38-year-old male athlete. So SP means status post. Right ACL, ligament of the knee, reconstruction. Brace has been removed, ambulating without an assisted devices. The physical therapy plan of care includes moist heat, that's superficial heat, to the right knee, active assist range of motion into knee flexion, hamstring gravity and TheraBand resistance exercise, and instruction open kinetic chain exercises for home for 2 muscles. Post-treatment, RX treatment, or TX is also treatment. Measure passive range of motion of right knee extension, both hip external rotation. Write a SOAP note for today's visit. So here are short-term and long-term goals. With all of that information, go ahead and give yourself a long pause and write yourself a little SOAP note for that. We can talk about that later. All right, welcome back. So here's another case that you could write a SOAP note. Practice writing your own SOAP note about. 88-year-old female, status post, SP, CVA, cerebrovascular accident, that's a stroke, admitted to your skilled nursing facility. She complained of limited strength to right side, inability to use stairs, inability to walk greater than 20 feet without assistance. We have our goals there. What would you remeasure? What would you expect that data to, and what would your treatment be? I know we're early in your education, but what do you think you would do with her? And then write that SOAP note again. Give yourself a little pause and spend some time with that. All right, so we can look at those later. I bet you they were really hard to write, those last 2 SOAP notes, and that's okay. We're going to get better at them. Here's the other thing you could do to write a SOAP note. You can write a SOAP note about anything you want. Sometimes these SOAP notes make more sense if you write against something that you know about, and then you get to learn the mechanics of the SOAP note rather than, treating this woman with a stroke. Well, we don't know anything about a stroke. We don't know anything. We don't have enough information about her problem set. We don't have a real plan of care. We have some short-term and long-term goals. So this is a really tough thing to do. So let's write a SOAP note that you can write against something you know. So if you've got a rugby game this weekend, subjective, rugby game at 2, patient states, rugby game at 2:00, excited to play. Objective, what happened during the game. And then your assessment, was it good? Was it bad? Any additional information? And then plan, what are we going to do next time to make the outcome better than it was this time? I've had students write SOAP notes about Thanksgiving dinner. I've had students write SOAP notes about getting their kid out the door so they can go to school on time. I've had students write SOAP notes about bringing their kids to a baseball game. I've had students write SOAP notes about their work, either as a chef or as a painter. So you can write a SOAP note about anything. I think if you do that, it'll help make sense on the organization of a SOAP note what information goes where. And then as we learn more and more about physical therapy, then we get to build on our knowledge base on physical therapy and then just applying our SOAP note with that. So what I want you to do, it's not a graded assignment, but write a SOAP note about something you know about. Could be about an exam you had, although you don't have the graded data yet. But yeah, what can, anything that you're familiar with, write it about. And if we can work on that, then when we get to real SOAP notes, you'll be much, much better. So you can do that, and we'll talk about it in class next time. I hope you enjoyed this, and I'll talk to you guys soon. Bye bye.